This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. Have you read the paper Supportive Self-Management Program for People with Chronic Headaches and Migraine, a randomized controlled trial and economic evaluation? With me to discuss is Martin Underwood, who's an associate with the Warwick Clinical Trials Unit at the Warwick Medical School in Coventry, UK. How are you, Martin?
I'm good, thank you.
Well, thank you for this wonderful work. So I want to start out with, why did you set out to do this study in the first place?
Well, basically, there's very little research on drug interventions for people living with chronic headaches. And just to be clear here, when I talk about chronic headaches, I'm meaning an epidemiological definition of chronic headache, because that's where I come from working as a GP, in that we don't see people with precisely organized headache diagnoses. These are not people who've been to headache clinics. And we're interested in pain self-management programs that are commonly used in a lot of other chronic pain syndromes. For example, back pain is the one people will know most about. And those are widely used. And our idea here was that we could use this sort of approach, but there would be added value of doing this in a headache population, because very many people with chronic headache disorders haven't had a good diagnosis. And if we can direct people towards the appropriate drug treatments and away from medication overuse, then we thought there's a great opportunity to really help people with what can be a very disabling disorder.
So how was the study designed?
So this is a randomized controlled trial, and our primary outcome of interest was the HIT6 at 1 year. But of course, we also measured headache days and a range of secondary outcome measures. We did a huge amount of preparatory work before starting on this trial. We did systematics reviews of what it's like to live with headaches, what the prognosis is for chronic headache disorders, what interventions might work, what outcomes might be the best ones to do. We developed and tested a telephone classification interview so we knew we were getting the right people into the trial. And we tested recruitment feasibility. So we did all this work to prepare for the trial. We then, based on all of this, developed our self-management support intervention, the CHESS intervention, which consisted of 2 one-day sessions with 2 facilitators, both health professionals. Originally, we had planned to do this with a health professional and somebody living with chronic headaches, but we found that the people with headache disorders found it really hard to be able to commit to deliver on this for the days, which is why we didn't use lay advisors in this particular project. After these 2 general sessions on education and advice about self-management strategies, they then all had an individual consultation with a nurse trained in how to do diagnostic assessments in headache, and were advised about which medications to take and, if appropriate, advised against about the hazards of medication overuse. We originally went for a population which were a mixture of chronic tension-type headache and episodic migraine, and chronic migraine as our overall population, because we were looking here for the effect you would get in the sort of unsorted populations that you would be seeing in primary care. But in fact, what turned out is the vast majority of our patients had migraine, so our primary analyses are actually on the 2 populations of the people with chronic tension-type headache and episodic migraine, and the people with chronic migraine. And we set out with a target sample size of 523 people with migraine.
For our listeners, HIT6 refers to the headache impact test. So why did you recruit patients in primary care?
We went for primary care because this is where we thought the biggest unmet need is. because those people who've been to secondary or tertiary care, they've seen a headache specialist, they've had a proper headache diagnosis, they should already be getting plugged into the proper into support systems and getting the best possible advice. But at least in the UK, and it may be true, probably true elsewhere, the vast majority of people with chronic headache disorders don't get to see an expert in headaches. Therefore, addressing the issue here of how best to get a diagnosis and directing people towards the best treatment, this is where the greatest potential was.
And what were your major findings?
We recruited 736 people. 727 of these people had migraine. So this makes it one of the largest trials in non-drug treatments for headache disorders, specifically here migraine. And about half of these people, 56%, had medication overuse headache. So they're very much the population we were interested in. We delivered 42 lots of group interventions. But when we got to look at the results, we had no effect whatsoever on the headache impact test, HIT6, or on headache days, or on any of the secondary outcomes at 1 year. So for our primary analysis, there was no effect from the intervention. We did find a small effect on the HIT6 at 4 months, but the p-value for that was 0.049, so difficult to claim statistical significance. But at the same time point, they had 1.5 more headache days in the previous 28 days. So not a benefit there either. We looked separately at the people with chronic migraine and people with chronic tension type headache and episodic migraine, and there was no difference in effect in those groups, so it doesn't work for either of those groups. We also looked to see whether severity of how badly disabled they were at baseline made a difference. It didn't, and neither did anxiety or depression. We had no effect either on drug use in either arm during the duration of the study. We did have some effect on pain efficacy, which was the underpinning principle of the intervention, but only at a couple of time points, and it's not a key target variable. So the summary of this is that a supportive self-management program for people with chronic headache disorders, chronic migraine, chronic tension type headache with episodic migraine, when compared to a relaxation CD, essentially usual care in British general practice, is that it has no effect.
Were you surprised by these findings?
Yes, we were very surprised by the findings. We've had a lot of soul searching about why we have got these results. And in a separate paper published fairly recently, we've done a process evaluation to try and work out what was going on, to work out why this might not have worked. And we still don't really have the answer to that. There was good fidelity. The intervention was delivered as intended. We had reasonably good adherence compared to other studies. About 2/3 of the participants achieved minimal adherence to the intervention, which, given how difficult it is that some people with headache disorders find to get to sessions like this, we thought that was quite good. And the sessions were valued by the people who took part. When we talked to people who'd been there, they thought they were really good. So honestly, we're not clear why this intervention hasn't worked.
And what do you think the implications are for clinical practice in managing patients with chronic tension type headache and episodic migraine?
Well, at this time, the use of this self-management program, and based on the previous research, other behavioral interventions for people with chronic tension type headache and episodic migraine or chronic migraine are not supported by the evidence. At this time, the use of this self-management program, and based on very limited previous research in behavioral interventions for people with chronic tension type headache or chronic migraine, this is not supported by the evidence.
Did both groups improve and then there was just no difference?
Both groups improved compared to baseline. And that is what you would expect in any study of people with chronic painful disorders.
Well, could this be an option for patients that may not want to use a CD or practice relaxation?
We didn't think the CD and the relaxation would really have any therapeutic effect, but we know that people value these kinds of materials. But in the absence of evidence to show that there's any benefit from this, no, I don't think the approach that we've tested is something people should be using, because it's consuming their time, it's consuming their energy. There are resource costs involved with the delivering this intervention. So no, this is not something we should be implementing.
So based on your findings, essentially a negative finding, what are the next steps to better understand potential efficacy of self-management programs in general for this type of population?
This approach that we have used has clearly failed on our clinical outcomes, the things that we measured that are important and relevant to patients. There was, however, just a very slight suggestion that in the cost-effectiveness analysis, although it costs more money to deliver the intervention and it didn't achieve statistical significance, in the quality-adjusted life years, over the sort of measure that health economists use, there was a small gain. So it is just possible this sort of approach might have a benefit, but we might have to measure a very different outcome. But the outcomes that we measured map directly back onto the sort of core outcome measures that should be used in trials of this nature. So it needs a very big step back and a think about how we might approach this. I think if I was putting together another trial in the near future, what I would do is I would be looking at a much more homogeneous population, looking at a secondary or tertiary care population, all people who've been through the mill of everything with chronic migraine, the people who've really got to the end of the road, they've failed with all the drug treatments, and look very much at this very tightly defined group to see if we could do some more to help them. I would also think about how we delivered the intervention, because of course we did all of this before COVID, and before COVID it would have been very difficult to deliver an online intervention. But now everyone is so much more used to working with the likes of Teams or Zoom, this sort of thing. We may be able to deliver this as an online intervention, and that might also improve accessibility for people who are having a lot of trouble with their headaches to be able to log in and do a session online. So really, in summary, we need some more new original work on the experience of living with chronic migraine, and then to find out if there are better targets for our interventions and better ways that we can deliver the interventions. But until such time as we've got evidence to show that these things are effective, I don't think it's the sort of thing that we should be offering patients.
Well, I think there was a lot of insight in setting up a clinical trial like this, and certainly for a deserved population. And you're completely right that future studies looking at technology as a resource might be optimal.
I think there are good opportunities to do this with new technology. And over the recent past, we've been, as a unit at Warwick Clinical Trials Unit, we've been exploring this, and we're delivering online interventions for other populations, but not for the headache population at the moment.
Well, don't give up on us, and thank you so much for being here.
Thank you for having me.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients.